Good evening, everyone. Myself, Dr. Rakesh. I'm an ECMO physician and clinical director for Critical Care and Anesthesia Services, a NASA group of hospitals, Hyderabad. The next few minutes, I'm going to talk about the nursing care, especially in ECMO, physiotherapy role in ECMO, and then pruning in ECMO. So, how they are going to help in the recovery of these patients, especially ECMO patients, when it comes to disclosure, I don't have any conflicts of interest to disclose here. So, before going on to the topic per se, so what should be your ideal team before going for the cannulation of ECMO patients here? There should be two intensivists, an ECMO intensivist should be there, ECMO trained guy, and one cardiothoracic surgeon should be there. But generally, I emphasize on ECMO intensivist cannulating your patients, and one resident for monitoring the cannula positioning and monitoring and taking care of the patients. That's called clinical management. There should be a perfusist in your team who should be priming your ECMO circuit and then maintaining the circuit. And there should be a respiratory therapist also in the team who should be taking care of your lung productive management and even the ventilatory settings also. Apart from all these things, the most important part of your team comes with the nurses. During initiation, maintenance, decannulation, or any time of the patient's stay inside the hospital, nurses play a key role in the recovery of your patients. So the nurses should comprise of two senior nurses and one registered nurse should be taken care of. And you should have a radiological technician who should be trained in ECMO for maintaining all your aseptic precautions too. So let us see what is the role of nurses, what are the roles of respiratory therapist or a physiotherapist in the ECMO recovery and how they are going to help in the recovery of the ECMO patients here. So coming to the nurses in their pre-ECMO management, so they should be trained enough in doing a proper documentations. They should be taking consents, orders, and then current management, what the patient is on. On the bedside, they should take care of ECMO. They should take care of the patients. They should take care of the requirements of ECMO, like the blood transfusions that are required, heparin, drugs that are required, sedations, narcotics, fluids, and everything should be arranged by the bedside nurse here. Pre-procedure, and they should be very much careful that how the bed they're going to arrange, how the space management they're going to do that. So we'll see at various levels what is the role of nurses while you're dealing with an ECMO patients in the various phases of ECMO, like the initiation phase, the management phase, and then maintenance phase, and then the decannulation, post decannulation care. During the initiation phase, what's the role of ECMO nurse here? So they should make sure the crash cart is there in the close proximity of the patient. That means that when I say the crash cart, it should be an ECMO crash cart. It's not like a routine crash cart in the ICU. This ECMO crash cart is like it should host all your ECMO cannulas, an additional venous drainage cannulas, additional arterial cannulas, the unit of guide wires, additional connectors with layer locks, additional step up and step down connectors. So all the things which are required during initiation should be kept in an ECMO crash cart. So this is going to save your time and this is going to save the life of the patient also. So these ECMO crash carts you can easily because of these ECMO crash carts. So whenever there is a complication like cardiac arrest in a VV ECMO, you can immediately convert it into hybrid kind of ECMOs here. And then inserting the fecal management systems and then Foley's with all the necessary lines is also the role of an ECMO nurse. In Indian population, generally, we are not using these fecal management systems, and you should be pretty much careful while poking any patients or while causing any mucosal damage, especially in the ECMO phase, maintenance phase, especially in the maintenance phase of an ECMO here. Preparing and positioning the patients, placing appropriate mattresses. So once the patient is on ECMO, like moving the patient is going to be difficult for you. So keeping an alphabet with a deflated state before cannulation. Once the cannulation is there, simply connect it to the power and then inflate the bed. That's going to save a lot of energy. That's going to be prevent a lot of complications for your patients. And arranging pillows and bolsters for your patient's positioning. So I want my patient in a supine and also in a hyperextended hip positioning should be there. So arranging the patient in a particular position so that the natural course of the femoral vessels which they take a sharp turn behind your inguinal ligaments can be prevented and they can be converted into a straight line course here. Clip the hair on preparation. The side preparation should be done by the bedside nurse and then making the bed that is spacious. So the ECMO bed should have the echo machine, it should have an ECMO trolley, it should have a ventilator, it'll have all your the infusion pumps. So technically it is two ECMO beds that an ECMO machine is actually that an ECMO patient is actually occupying here. And then next most important thing is the communications. So they should be collaborating with all the team members like the doctors, physiotherapists, and then the perfusionists here to make sure the necessary equipment has been arranged. In that way, they're playing a very crucial role and then ensure the liberal supply of gas pieces. So there might be chances of severe bleeding during initiation phase. So make sure a lot of gas pieces are there in your ICU, wherever the place you're initiating the ECMO. be aware this is I mean, like, you should always think that it's a responsibility of the ECMO initial, I mean, like the intensivist or a unit head here to make sure all these things are available. But the nurse, I mean, like all the team members should know the protocol starting from initiation to decannulation itself. Then only your complications will come down. It's not the only intensivist or an ECMO director's responsibility to make sure all these things are happening in harmony. It's the responsibility of each and every person in the team to know what are the steps that will happen and what are the complications that happen at each and every step, and make sure the baseline observations were documented, because this is a trend of these observations that gives us so many differentials in the long run of the ECMO here. And ensure the contact numbers. So the ECMO nurse who is on bedside should have the contact numbers of all the on-call perfusionists and ECMO intensivists. So there are some centers where there are perfusist luxury is there. You can post a perfusist 24 bar 7 on the bedside. If your perfusist is not available, yes, even the ECMO nurses will do the job, but make sure you do in collaboration with the perfusist, because he's technically more or is technically more skilled than the bedside nurses here. So make sure you are in harmony with the perfusist and you're trying to manage the patients here. And ECMO nurse has to ensure 6 tubing clamps which are readily available on the bedside, and they should be properly always in communication with the respiratory therapist and the intensivist for the ventilation orders or the new drug orders and all those things. During the maintenance phase, the most common problem which we generally face are the infections here. So it's the responsibility of the bedside nurse, it's the responsibility of the whole team to maintain the strict infection control practices. And when it comes to sterilizing the circuits, I mean, like ELSO advocates not to use any alcohol swabs or chlorhexidine washes. It's only using betadine to sterilize the circuits. If you're adding an extra part in the circuit or something like that, and make sure that access to the patients or the bedside is restricted. Don't allow everyone from the patient's family to see the bedside patients, because they should have a restricted access with the essential personnel only. And removing, see, two things are very much important here: placing the necessary lines, removing the unnecessary lines. Both of them is completely important when it comes to ECMO. That should be taken care by the bedside nurse. And positioning of the ET tube, securing the ET tube and maintaining the ET tube in a sterile way. And she should be, during the maintenance phase, she should know what is the color difference, which is a drainage limb, which is an arterial limb. She's not a simple bedside, like, so who are being trained onto the ECMO, or whenever you say it's an ECMO nurse, she should be knowing basic complications of ECMO. She should be knowing basic monitorings of ECMO, color of the blood that is returned, and she should be knowing how to ensure the catheter security during patient movements. So your ward boys and IMRs who comes for patient positioning and all, they might not be knowing the importance of these cannulas. They simply turn the patients on their own, or because it's lack of knowledge, they think that the patient is like any other routine ICU patient. But the bedside nurse should take care of all these responsibilities and make sure the cannulas are not coming out or going in while doing any positionings. Apart, this is the basics of ECMO management when it comes to the nursing side. So apart from that, routine assessments like your routine ICU patients, like heart rate monitoring, blood pressure, saturation should be done. Hourly assessments by one more important thing a nurse, a bedside ECMO nurse should do is neurovascular observations. When I say neurovascular observations, it's a GCS assessment and time to time basis, and then the vessel status. I mean, like, what I mean to say is the cannulation site hematoma formations on a routine basis should be monitored. So urine output, temperature, EtCO2, these things can also be routinely monitored by an ECMO bedside nurse. So all these things are the routine monitors. Coming to the personal care of the patient on ECMO, especially when they're using an oral care, try to use swabs or smooth tissues or smooth instruments here. Don't use any toothbrushes. These mucosal damages will lead to tremendous bleedings in an ECMO patients here. And don't try to shave with wet razors. Try to use the clippers. Don't use routine tracheal suctionings and mouth suctionings, which is not warranted, and even that's not going to add any benefit for the patients. Unless the patient is getting drooled up with secretions, try to do suctioning. That too with soft tipped catheters like silicone catheters you can use, or otherwise you can go with a Foley's catheter also. So many ICUs converted from a suction catheter to a Foley's catheter. Though it's costly, it is causing less trauma to the patients, and especially in ECMO and hypernized state, this minimal trauma will lead to a massive hemorrhage here. And don't try to dislodge any clots over the wounds or any clots over the cannulas and at the insertion sites also. And don't try to do recurrent venipunctures too, because that also will lead to hematoma formations. That is also very much dangerous here. So restriction in mobility and then doing the mobility. Both of things are equally important here. So the patient is completely sedated and paralyzed. Try to restrict the mobility of the patients and ensure appropriate alphabet is placed, and the daily pressure of care should be taken on regular basis. And when you're doing a log rolling or a positioning change of the patients for your beds or prophylaxis, make sure one registered nurse always ensures the circuit and cannula safety here. And if there's significant exudates, unless otherwise there's significant oozing or exudates, don't try to change the cannula plasters. Don't try to change anything in the cannula sites also. So to make sure the ECMO intensivist are on the bedside, and then try to change the cannula plasters, and then try to do some suturing kind of thing. The patient is bleeding very much profusely here. And one more important step is like while pulling the dressings of the cannula, don't try to pull it away from the insertion site. Try to pull towards the insertion site such that the chances of the cannula getting dislodged will be pretty much less. There's ongoing use. You can also use some calcium alginate or sorbitol and alginate dressings also can be tried here. So that also can be tried. That also can be applied. So ensure cross-matching of PRBs are available, daily electrolytes monitoring, daily blood pressures monitoring, and this is a routine monitoring is what we generally do for all our patients here. But especially when it comes to ECMO, because the hemolysis chances are pretty much high, doing a complete blood picture on a daily basis and then a platelet count as and when required should be done. And blood cultures during the spike of the fever should be done as and when the fever is there. And pre and post oxygenator ABG should also be monitored by the bedside nurse, but also in conjunction with the perfusionists here. And ACT and APTT should be checked as per the hospital protocols. I'm not advocating it should be done every second hourly, like those scenarios. It depends upon the patient to patient. So once the patient is along with you, your ACT monitoring and APTT monitoring should be done. Whenever there is no discrepancy, we do ACT every 6th hourly. And if the patient is improving, no bleeding, we'll do it 8th hourly, 12th hourly also. If there is a discrepancy between ACT and APTT, we might be doing this 6th hourly or 8th hourly also. It depends upon the patient scenario, clinical scenarios. So during the weaning phase, what is the role of a ECMO bedside nurse or ECMO nurse here? During the weaning phase, the role of nurses will be like those nurses should be knowing the basic knowledge regarding the signs of weaning. So they should have an improvement in the oxygenation. They should know what are the various signs of improvement when it comes to ECMO patient. What are the various signs of lung improvement? What are the various signs of ABG improvements that are going to happen? Because if they know that signs, then they'll come and prompt to the ECMO intensivist saying that the patient is recovering. You can try doing some spontaneous breath trials can be done, and spontaneous oxygenation case can be done here. And before decannulation, they should be always seeing the clotting factors and platelet levels, and they should always monitor the heparin infusions. So once the patient is decannulating, you need to discontinue heparin infusions 2 to 4 hours. So these things should be done by ECMO bedside nurse during the initiation phase, maintenance phase, and weaning phase. And weaning phase is pretty much important. Before decannulating, make sure 2 senior residents or ECMO trained intensivists are there on the bedside. Direct pressure application is generally sufficient. Then there should be a coordination between intensivist, bedside nurse, and then the physiotherapist for the sedation plans and pain management here. And successful Doppler assessment should be done in the decannulated limbs after the removals. And post decannulation, what are the various steps should be done? Hourly cannula site assessment by the bedside nurse should be done. Higher chances of hematoma formations are there. Monitor the clotting time, hemoglobin, and platelets. Ensure the access sites are stabilized. Don't try to dislodge the clots, and maintains the enteral feeding and report the blood loss. It's just like once the patient is weaned off ECMO, you should make sure all these things should be done on the bedside nurse here. The most important part is monitoring the cannula sites here. If the cannula sites are being monitored, then the chance of hematomas are going to be very much less here. So in a nutshell, the role of the nurses in the bedside is like communication with the whole team, making all the arrangements required for the ECMO cannulations to prevent the complications and preventing high risks of nosocomial infections, closely watching for the signs of infection on the bedside. So this is the ECMO chart, which we generally use it in our ICU patients. So wherein the bedside perfusionist or the ECMO nurse will document all the events, all the monitors and all the parameters that are required to monitor on the bedside in a daily basis here. So by doing this, you'll understand the trend of events. And by understanding the trend of events, you know the complications. You can prevent the complications coming too much early here. So that's the importance of ECMO nurse on the bedside. She is definitely, or the bedside ECMO nurse is definitely responsible for the faster recovery of the patients. So let us see about the respiratory care and rehabilitation during ECMO and how it is going to help you in the recovery part. So in our team, we need to have the respiratory therapist or physiotherapist or unphysiotherapists are required. They play a crucial role in managing ECMO patients. So it's not only the man management, it's from the literature support also is also there that the respiratory technicians and then the physiotherapists who are there on the bedside, they are very much improved. They're very much required for the effective interventions. They are very much required for your effective interventions. They're very much required for the improvement of the patient's health in terms of physically, mentally, and then preventing the patient complications like critical illness, neuropathies, or something kind of So all these chronic complications can be prevented if you have a good respiratory therapist and physiotherapists here. So let us see the physical rehabilitations part here. So ECMO patients, they're generally more prone because they're chronically sedated. They're staying in the ICU for months together. They might be having chronic pain, depression, anxiety, and post-traumatic stress disorder. And then they may take at least 3 years of that to recover from all these events here. So the best thing is to avoid all these complications. To avoid all these complications, rehabilitation is the only answer here. So the ICU acquired weakness should be avoided. The morbidity should be avoided, and then the weakness. I mean, like the wasting of muscle should be avoided. So all these things play a major role in the long-term physical and physiological well-being of the patients here. So are there any contraindications and complications for physical rehabilitations of the patients or physiotherapy in the ECMO ICU? Yeah, there are some contraindications not to go ahead with the physiotherapy. If the patient is having a critical hypoxia, if the patient is having hemodynamic instability or any unstable cardiac arrhythmias, when there's a chances of raised ICP, yes, you're not going to do a vigorous exercise for these patients. Unstable cannula sets. Every physiotherapist and ECMO team should know that the importance of cannula fixations, importance of cannula sites, importance of bleedings that is going to happen for your patients when you're doing all these procedures and maneuvers. And then monitoring the desaturation support with minimal movement. So once the patient is having a desaturation episode with minimal movements, yeah, you're not supposed to do vigorous physiotherapy for these patients. Whenever there is a change in the hemodynamics, whenever there is a shortened ECMO circuit here, you're not supposed to do all the physical rehabilitation procedures. So simple words, unless otherwise the patient is completely stable, unless otherwise his hemodynamics, ECG, I mean like the heart rate, pulse, every vitals has been taken care of or stabilized. Don't try to do the physical rehabilitations. Trying to the complications part, yes, you should always be careful of the cannula displacements or fractures. You should be always be careful of thrombus, and you should be always careful of leg swellings that is happening that is happening in your, especially in your patients. So these are the major things here. So before going on to the physical rehabilitations of any ECMO patient here, so you need to have an assessment flow chart. So you need to have an assessment flow chart. That assessment flow chart should be documented. That assessment flow chart should be completely filled up by the physiotherapist or respiratory therapist here. So there are so many things that points that should be like priorly that should be priorly taken care of here. So a pre-treatment safety risk assessment should be completed by the ECMO team prior to commencing physiotherapy. Bedside nurse should be involved with daily physiotherapy and respiratory care planning here. So location and security of the ECMO cannula should be taken into consideration. So when you're trying to do positioning change for the patients, or when you're going to do physiotherapy for your patients, make sure that the location and security of the ECMO cannula should be taken into considerations. Hemodynamic and respiratory stability also should be taken care. The respiratory treatment and rehabilitation process. The respiratory treatment and rehabilitation process, including the benefits and risks. Depending on the patient cognitive state, informed consent should be taken care. If necessary, analgesia should be optimized prior to the starting of physiotherapy to ensure the patient comfort is maintained. Sorry, yes. So what are the benefits of early mobilization in the ICU? Early mobilization of ECMO patients, early mobilization of ECMO patients is strongly recommended considering the beneficial effects. So what are the various beneficial effects which we do have for the early mobilization? Maintaining the muscle strength. So physical activity maintenance and health-related quality of life is maintained, and these patients will have less ventilator-free days, and length of stays in both the hospital and ICU can be maintained with early mobilizations. The following patient approach. So what are the various approaches we do have for the early mobilization in the ICUs or the physiotherapy? What is the physiotherapy menus that they generally do? So what they do early progressive mobilization of these patients. Active assisted exercises will be done by these patients. Sitting and standing positioning and active and passive range of movement exercises. Resistance exercises, positioning in bed and stretching should also be done on the bed only. So all these things will make the patient recover. So these are the various images where we're doing the passive exercises and then resistance exercises, trying to mobilize the patient out of the ECMO here and trying to make the patient walk on an ECMO here in spite of all these things. So only thing that you need to keep in mind is patient should be hemodynamically stable, no life-threatening emergencies. And then the third step should be patient should be completely conscious while you're doing these mobilization exercises here. Okay, and one more important tool for the physiotherapist is like neuromuscular electrical stimulation. It's just like your TENS machine here. So So what this will do? What is neuromuscular electrical stimulation will do? It's an alternative treatment adjuvantly used in all the bedridden patients. So if the patient is completely bedridden, unable to move his body from the bed, so what you're supposed to do, you can apply these neuromuscular electrical stimulations. So this will periodically send some electrical signals to your skeletal muscles. So that will maintain your muscle thickness, that will maintain the microcirculation, that will maintain the oxygen consumption and reperfusion of the patients. That's what it will preventing the muscular atrophy and critical illness polyneuropathy here. So it's a potential alternative to an active exercise. The patient is unable to do an active exercise of his own, or if the patient is slightly sedated, unable to follow your commands, you can go ahead with the neuromuscular electrical stimulation. So this is the device here wherein you can use it for different group of muscles. If the patient is unable to do that, and once you apply it for the muscles, it's like a passive exercise by the patients here. Cycling exercises generally, which is done by post TCAR patients and then post lung transplant patients. So this cycling exercise, what they do, they'll maintain your muscle strength here. So this is the device that we generally do for even for ECMO patients, even for the post transplant patients also. This cycling exercise will try to maintain the integrity of your lower body muscles also. And then the most important part is the strength training, either it's active or passive. Out of bed strengthening exercises, they include like muscle training of the lower extremities is done by our physiotherapists on the bedside. Dynamic quadriceps training, elastic band exercises, squatting and then standing up, weight training of upper limbs and weight shifting, sit to stand and bed to chair movements. All these things are generally done to maintain the muscle mass, to maintain the muscle strength, and to maintain or to prevent your critical illness polyneuropathy here. So these are the various steps that your physiotherapy friends will generally do on the ECMO patients, and not only ECMO patients, for any ICU patients here. So there's one more concept called as prehabilitations instead of rehabilitations. So it's a concept that is being developed in lung transplant programs or heart transplants program. So in these situations, what happens is prior going on to the ECMO itself, so we'll start the rehabilitation of these ECMO patients. We'll start the physical activity. We'll start asking the patients doing the physical exercise for all those muscles, which we do on a stepwise basis. So if it is done prior to transplant or prior to ECMO, we call it as prehabilitation. So it's like once you do prehabilitate the patient, the chances of your critical illness neuromyopathy, the chances of your bedbound state will be decreased in coming situation, in the coming post-transplant situations. Coming to the respiratory care, which is a part of the physiotherapy care, so which includes the airway management, especially when it comes to the airway management, these lungs, these severe ARDS lungs, while they are deteriorating or recovering, they'll throw a lot of secretion. So you should be actually suctioning the airway, maintaining the patency, and during the procedure, you should be securing the tube. And tracheostomy patients, make sure you're taking care of proper stoma. Ventilatory management, all of us know that there is something called as roll of 10, which is an ultra lung protective ventilations where you manage the least possible FiO2s with a PEEP of 10 and tidal volume of 4 to 6 ml per kg. And in ECMO patients, you can go up to 4 ml per kg also, targeting a planetary pressure of less than 24. VAP prevention is the basic strategy of doing all these respiratory rehabilitations. So what happens in ECMO patients, because the patient is not actively coughing, patient is not actively moving, chance of developing of VAP will increase here. And especially when it comes to ECMO and VAP here, new lung infiltrates in the chest extra of an ECMO patient, not necessarily because of an infection also, because these patients generally will have pulmonary edema that develops during a VA ECMO runs or VV ECMO runs here. So don't be like jumping into the conclusions that any new chest extra infiltrates is a VAP here. That does not completely holds on good for ECMO patients here. So you should be properly taking care of your oral care, ET suctioning, head and elevation, like the bundle, the VAP prevention bundle, which is generally used for all your IC patients, should be implicated here. But the only thing is, don't compromise on the cannula positions and safety here. And the frequent movement of cannulas inside and outside of your stomas will cause a lot of bleeding here. And pulmonary hygiene, yes, all the ECMO patients should have a chest physiotherapy routinely done. They should have a high frequency chest wall oscillations. You can use a dolphin vibrator also for that, and cough assist devices. And you can also use the positive and expiratory pressure devices like flutter device, Ecpella, and Quake. So what they do during the expiratory phase, they develop a vibratory kind of sensations or vibratory kind of movements into your lung. These vibratory kind of movements will stimulate the secretions which were there in the alveoli, and the patient can able to spit it off. So that's the major activity of all these PEP devices here. So we have various devices like Ecpella, Flutter, and Waller devices were available in the market also. Conventional respiratory care. So like all your routine ICU patients, ECMO patients demand the conventional respiratory care like humidifications, aerosol therapy, nebulization therapy exercises, And if a patient is non-ventilated, spirometry exercise and thoracic expansion exercise will also be done. So there are some interesting studies where they do that, where they have done if the respiratory based sweep of trial. So if there is a ECMO unit which was this study has been published in 2021, where they have done a spontaneous sweep of trial by the bedside respiratory therapist by trying the bedside respiratory therapist. So a daily respiratory therapy assessment of readiness to liberate from a VV ECMO patients with a severe ERDS. So they have found an interesting finding that if the bedside respiratory therapist is doing a daily spontaneous sweep of trials, and then the weaning part will be actually, what is it, will take an express path. That means the weaning will be done pretty much faster if it is done by a bedside respiratory therapist here. That's what they want to advocate here. So I generally feel that whoever might be there on the bedside, whether it's a respiratory therapist or an ECMO nurse or an ECMO physician, if they do daily monitor the patients, yes, your weaning trials and all your sweep of trials will be done on a daily basis by the bedside person who is staying there. The chances or the time of weaning will be decreased very much prior itself here. So in this study, they mentioned that reduced duration of mechanical ventilation and reduced duration of ICU length of stay has been observed for the bedside respiratory therapist assessment of readiness for the sweep of trials here. So by these two talks, what are our take-home messages like? Nursing care, which we already know how much important is there in the ECMO recoveries. Physiotherapy during ECMO is actually feasible and it's not a contraindication and is very much safe when performed by experienced team. When performed by a team who know the complications and if it is being executed in stages. So which stage they are in? So if the patient is in early stage or in a maintenance stage or a weaning stage. Early active and passive ICU physiotherapy will have positive outcomes in the quality of life. And respiratory care is a standard of care in the ICU, and ECMO is not a contraindication for a respiratory care. Only precaution is that because the mucosa is pretty much heparinized, make sure you do it very much gently. So respiratory care is not a contraindication. It should be done for all your ECMO patients also. So as stated in the world, in the ELSO and the practice in the world, more respiratory therapy should undergo ECMO training and include it in the scope of their practice here. So that is what the take-home messages from these two slides in these two classes here. So coming to prone positioning in ECMO especially. Prone positioning, when in ARDS generally it is indicated when the PF ratio is less than 140. So what this prone positioning will do for the lungs here, it allows homogeneity in pressure distribution, improves your ventilatory perfusion ratios here and reduces your volume-induced lung injury and ulnar stress and strain. However, but ECMO, during ECMO, there are some centers which say that proning is contraindicated, and there are some centers where proning is done in a proactive state. So let us see how much proning is going to affect your ECMO outcomes, how much proning is going to damage your patient or going to improve your patients here. So whatever might be, let us see it in the next few slides. So most important thing is a team effort here. So you need to have a proper team for proning any patient in an ICU or in ECMO, you need to have more number of people here. So this is actually the how is a prone patient looks like on an ECMO. You need to have a good length of ECMO circuit for proning these patients. And especially in this kind of obese patients, you need to have proper team here. So this is a proning video which we generally do in our ICU. We advocate the log roll technique where the patient has been sandwiched between two bed sheets, and there is one person who is taking care of ECMO machine and the color changes, and there is one person on the head end who is taking care of ventilators and then the tracheostomy stoma, and at least 5 to 6 persons were required on the both sides. So and then pull the patient to one side. If possible, try to keep your legs here. Try to pull the patient onto your thighs, and then do a log rolling. So while doing this log rolling, yes, you can see some drag on the ECMO cannulas here. So without that leader who is taking care of ECMO circuit, if you prone the patients, you might ultimately land up in cannulas getting dragged and then either disconnected or the cannulas being dislodged from the patient's body. So ultimately, within a matter of seconds, if the patient is ECMO dependent, we might see the mortality here. So you can see how simply the proning is done in our unit in a span of hardly 20 seconds to 20, I mean like in a span of hardly 1 minute. So if you have a proper trained team who knows the complications, you have proper leader for this, yes, proning can be done pretty much easily here. But how much it is going to help for the ECMO recovery is still the question or still the debate that is actively going on in the ECMO ECMO practicing units here. So let us see various studies here. Prone positioning on ECMO, whether it's advocated or it's not advocated. So before going on to that, what does proning do to the patient who is on ARDS? So it's going to increase your ventilatory perfusion ratios, So homogeneous inflation of the lung that happens here, decreasing the risk of tidal hyperinflation of the non-dependent lung. That increases your oxygenations because there is a better ventilation perfusion, oxygenation improves, and then there is a better carbon dioxide clearance that happens here. And also, because of better carbon dioxide clearance, because of better oxygenation, or alveolar unloading also happens very much good here. So patients, there is a reduced impact of corpulmonal during proning here. And dorsal lungs will require higher circulations rather than the higher, like the apical lungs here. So the drainage, the opening up of the alveoli, which were dorsally, happens very much good. Your oxygenation improves, your gas exchange improves, your hemodynamic effects will improve. And ultimately, because the patient is positioned in such a way that the dorsal lung secretions can be easily drained from the respiratory tract or from the tracheostomy side, your chance of hospital-acquired infections will come down. So, but before going, there are some questions to be answered when it comes to the prone. So the science, we all know that how proning is going to help that. We need to understand the outcomes of the proning and then the evidence of proning. So if you want to have a closer look at it, so there is an electrical impedance tomography findings which were depicted on the graphs here. So the upper graphs is the patients with a compliance gain. The lower graphs is the patients with no compliance gain. And there is an x-axis and a y-axis. The x-axis, there is a proning time that has been depicted, and the y-axis you have tidal impedance and electrical lung variations that has been depicted on the y-axis here. So if you see, the tidal impedance has been gradually increased when the proning has increased to from 0 hours to 6 hours, 14 hours, and 16 hours. And post proning, SP means the post proning part here, and the tidal impedance has been completely maintained. So that's the that you can obviously see in this particular kind of graph here. And then local tidal impedance variation, the blue part is there. So as the proning duration increases, the brightening of the blue that is happening, and the local compliance variation is also improved. But this happens in the lungs with a compliance gain. In the lungs with no compliance gain, yeah, you might see some amount of electrical impedance that and tidal impedance that has been improved during 16 to 16 hours of phase. But immediately after proning, it reaches to the baseline, and even it will go further negative also. That means that in patients with no compliance gain, proning is not going to help you a lot here in these situations. So what they have done here, they have predicted these by taking this data, they have predicted these graphs here. So they have depicted the static compliance, they have predicted the electrical impedance of the lung here in various zones. So all these studies says that in patients with there no compliance gain in the lungs, proning is not going to help you. In fact, it's going to deteriorate the situations here. So let us see what are the various studies that are done in proning pre-COVID and then the post-COVID era. Pre-COVID era, there are so many studies from Germany, France, Italy. And if you see the baseline PF ratios and you see the indications, they're not pretty much clear. Every center have their own indications. For example, if you take the study from Germany, they have severe hypoxic ARDS, but the PF ratio has not been defined here. From France, the PF ratio 70 has been taken and the P plateau of 32 has been taken. Failure to adapt to wean to ECMO after at least 10 days of ECMO is the criteria which they have taken it here. So at least 7 days is the criteria taken by the France. And refractory hypoxia with the PF ratio of 8. So there are so many indications for proning from different studies here. And they have done different durations, 8 hours duration. Some studies have done 24 hours durations. Some centers have done 7 to 16 hours durations. Some have fixed regimen, some have variable regimen. So what you need to understand is that this proning, when to do proning, there are different centers which have kept their different guidelines here. The most common guidelines in Indian setup generally what to do is that once you try to maintain the patient for around 2 to 3 weeks of ECMO, in spite of that, if the patient is not recovering and if still the PF ratios are pretty much less, like 60, we used to take it as a cutoff point. So in those situations, we will prone at least for 16 to 18 hours. Because in the previous slide, what you have seen is that the maximum benefit of tidal impedance, the maximum benefit of electrical lung impedance, the maximum benefit of compliance gain that you are seeing that happens after 4th hour or 6th hour of proning to till 16th hour of proning. So generally all these studies will come up and then even the Prosiva trial says at least 16 hours of proning. So all these studies will say that it should be done at least 16 to 18 hours in a day. And then the indication changes from center to center. It's always objective also. So this is one study where they have studied prone positioning during veno-venous ECMO during ARDS. I think Ramanathan sir was also involved in this study here. But what's the important point is that the P ratios, if you see the significant P values are noticed only in three parameters: the PSCO2 levels, the PF ratios, and driving pressures. That means that proning has benefited in only three parameters. So if you do a patient on ECMO, if you do a proning for a patient on ECMO, your PaCO2 levels will improve. If you do a patient proning on ECMO, your PF ratios might improve. The driving pressures will improve. So apart from these things, the remaining parameters does not have a statistical significance. The p-value is more than 0.05 here in the remaining parameters here. So if you take the essence of all the studies, apart from the positive findings here, you have some negative findings. ECMO duration prolonged by 9.5 days if you're going for proning. In ICU, the length of stay has increased by 15 days, and there's development of low-grade pressure sores here on the front of the body here. So coming to the part of the evidence, this is from one more trial. This was the same trial. What they have done is that they have done the pooled survival of all the patients on proning and ECMO. They have found to have 57% of them have survived. And there are around 7 studies they compared the survival of the patients versus proning, in proning versus no proning, where they have seen a confidence interval of only 0.92 to 1.55. And there is no significant covariates associated with the pooled cumulative interval. So what does it mean exactly here? So if you take the unadjusted mortality here, the ICU mortality is 52.8 percentage versus 40 percentage in proning patients. So that's the versus 40.8 percentage. So if you have completely matched it, the mortality of the proning versus supine patients is hardly around 10 percentage difference, which we generally see, which is statistically not that significant. Even the graph, even the Cox regression graph also shows that proning is not significantly associated with reduction of mortality. So there's no mortality benefit here. But the only thing is there is some improvement in the PF ratios. There is some improvement in the carbon dioxide clearance. There is some improvement. There is some improvement in the lung recruitment, driving pressures itself. So those are the take-home messages from the proning part. This is one more study which was done by Lauret Papazian. So wherein they have done 1,814 patients evaluation. They underwent proning here, and they have seen the mortality of 54% in patients with proning and 41% without proning here. And if you can compare again here, the duration of mechanical ventilation has increased by 11.5 days. So with the effect of proning, but there are no major complications that has been reported here. So to conclude or to come to a conclusion, prone positioning in mechanical ventilations versus the prone positioning in ECMO. In a mechanically ventilated patients, prone positioning reduces the driving pressure. There will be an improvement in compliance. There will be an improvement in gas exchange. The outcomes improve pretty much in proning. In the PROSIVA trial, the mortality benefit has been shown in ARDS with proning. But the proning in ECMO, what is going to do? It's going to improve your respiratory mechanics a little bit. It's not like completely gas exchange. We are not very sure whether the gas exchange is because of the proning or gas exchange because of the ECMO parameters that has been improved at all. But this is definitely leading to prolonged ECMO run and ICU length of stay. We need a lot of studies like the prone ECMO studies, which is going to be published in the near future to understand the pros and cons of proning here. So to conclude this, prone positioning during ECMO, it improves the survival of the patients with moderate to severe ARDS patients, not in ECMO guys, but prone on ECMO, it is safe, it can be done. It's not a contraindicated thing. It improves your gas exchange, it improves your lung mechanics, but mortality benefit, we need a lot of randomized control trials to get it off. Indications, duration, and frequency. Yes, you have seen the comparison of various trials and then various trials in the table. The indications part, there is no clarity. The duration part, it's there, it's clarified. The guidelines were there when it comes to ARDS and proning, but there are no guidelines like how much duration of proning should be done in ECMO. There is no clear-cut value in this. The duration is not clearly mentioned anywhere. So we need guidelines on this, and the frequency, like how many times, whether it's a fixed dosage or it's an alterable dosage, should also be considered. And the last thing is we need multiple randomized trials in this particular aspect. And then I think Ramanathan sir is coming with some trial which is going to be revealed in the next coming international conference where they want to see the effects of proning in ECMO, the mortality benefit and the various side effects of proning and various benefits of proning in the coming trials. But definitely one take home message is we need a lot of randomized control trials to see the impact on the survival on ECMO patients, especially proning and ECMO here. So thank you so much, guys. So any doubts, I'm happy to take.